everyone. Thank you so much for having me here. I'm a different height to the last speaker, so let me know if the microphone needs moving. So yes, as Annette said, I'm a postdoctoral researcher here in Oxford. And for the past 5 years, I've been conducting an anthropological study of researchers working on issues related to overdiagnosis and cancer early detection. Or in other words, I've been conducting an anthropological study of some of you guys. Sorry. So by which I mean I've been carrying out long-term participant observation at conferences like this one, and I've also done a number of interviews with researchers, clinicians, patients, and members of the public as well, specifically focusing on the topic of cancer in the UK and these tricky issues of early detection and overdiagnosis. So what I didn't realise when I started doing this work was that I was walking into a field that is really highly polarised. And this is to the point that it's not infrequently described as a battlefield or a war zone. And so I was inspired to study this, and I was drawing on anthropological work like this one. So this is a book that was written in the 80s by Hugh Gustafson, in which he spent a lot of time with researchers working on developing nuclear weapons, and he also spent time with anti-nuclear activists. And his work was trying to understand how people can reach such different perspectives on seemingly the same thing. And so I was trying to do a similar thing in the field of cancer early detection and overdiagnosis. So I'm going to talk about a couple of my findings today, particularly focusing on this landscape of polarisation, trying to understand why we've got to this point, and how we might do things differently in the future. And I think that involves thinking about how we engage with people who disagree with us. And so my focus is on cancer, but I think some of this might be applicable to overdiagnosis more generally. So I wanted to start by checking that we're all on the same page. And I think we've heard a lot about cancer over the past couple of days, so this probably isn't necessary. But just to give you the headlines, cancer early detection is based on this idea that cancer is a disease that develops through these nice, neat, linear, progressive stages, beginning as a kind of localized condition and then eventually metastasizing. And obviously the premise of early detection is to intervene earlier in that process and stop these end stages from occurring. Now, 2 or 3 decades on cancer overdiagnosis has highlighted that in some types of cancer, progression is more variable than we once thought. So some cancers grow very slowly, or maybe even not at all, and some might also regress. And our early detection efforts diagnose those cancers as well. And so when we find a localized cancer, we call it an early diagnosis, but we don't actually know how long it's been there. Perhaps we just didn't see it, but it has been there a long time, but we don't know because we hadn't tested before. So that's why I put early on the last slide, early is in scare quotes, because we call it an early diagnosis, early detection, but we're bringing temporality into it, but usually we don't know how long it's been there. So this diagnosis of conditions that are unlikely to progress to cause harm, we might call overdiagnosis. Now, in my work, I argue that researchers tend to fall somewhere on this spectrum, from being very concerned about overdiagnosis to being very concerned about early detection. And this depends on whether they prioritise the harms of medical intervention, so this might be overdiagnosis, overtreatment, and so on, or the harms of not medically intervening, so that might be metastatic cancer, proponents of early detection would say, or perhaps death as well. And I think it's important to note that there's a lot of agreement throughout this spectrum. But despite this, the field has become quite polarised. We've got different conferences, different professional networks to some extent, and sometimes we think of the field in terms of these conflicting sides. And I think there are good reasons for this. Criticising cancer early detection is a really controversial thing to do, and I speak from experience when I say that. A researcher who was working on prostate cancer overdiagnosis once described to me that he'd been told by someone who had read his work, which was about the harms of PSA testing. He was told that he would smell the flesh of dying bodies from his ivory tower. Yeah. And in the field of cancer overdiagnosis, it's not that uncommon to hear stories of researchers who criticise cancer screening or who talk about the harms of cancer screening being told that they're killing people or they've got blood on their hands. And this is by virtue of the fact that they're challenging this vision of early detection. And in that context, it's perhaps not surprising that we form really tight communities at conferences like this one. We need allies. The overdiagnosis community is so tight that it's sometimes half-jokingly referred to as a cult or a clique. And I should note, these are stock photos. These are not attendees of this conference. And this is also a stock photo. These are not attendees of this conference. So why is this field so polarized? How has this situation arisen? And I'm going to talk through 5 reasons for this, and then possible solutions, or possible ways we might think differently in the future. So work on overdiagnosis presents a challenge to people's fundamental ideas about what cancer is, i.e. that it's a progressive and possibly a fatal disease. And when we publish work about overdiagnosis, or we talk about overdiagnosis, we're saying, well, cancer might not be progressive and it might not be fatal. And that's a challenge to the notion of what the disease is, and also to the fundamental premise of early detection. And when we do that, in the process, we undermine the hope that narratives of early detection can bring people. And a paper recently described this process of talking about overdiagnosis and taking away this hope, or complicating the hope, as like telling people Santa Claus isn't real, which I thought was a useful way of describing it. I think in the field of overdiagnosis, we spend a lot of time talking about commercial drivers of early detection, greed, vested interests, which is obviously really, really important work. But I think maybe we don't say enough about how often early detection is driven by grief. At least in the field of cancer, these early detection campaigns are often driven by people's stories of either losing loved ones to cancerous diseases, or they're driven by doctors who talk about their experiences of caring for people with metastatic disease. And often these campaigns are motivated by the hope that other people might not suffer in the same way. And when we talk about overdiagnosis, we present a threat to that, which is potentially a complicated thing to do. And this is something I've written about in a slightly different context. So I've written about my experiences of coming to understand my own melanoma diagnosis as a potential overdiagnosis, having once quite simply identified as a cancer patient. And I've argued that we probably do need to think carefully about what it means to challenge this hope of early detection, particularly for people who have already become patients, for whom our work on overdiagnosis might present a challenge to their identity and to the story they tell themselves about their life. I'm not actually going to talk about that today, but if you want to hear about it, I'm going to talk about it at 4 o'clock later in room 6. So this hope that I'm talking about is also really highly moralized. We have this culture of healthism, which is this kind of moralized idea that individuals are responsible for their own health, and it's morally good to reduce your risk of disease. And when overdiagnosis challenge that, we're disrupting this model of what it means to be a good patient and a good citizen as well, and that's a complicated thing to do. So another factor that makes discussing overdiagnosis difficult is our really heavy reliance on large-scale population studies, which are obviously really, really useful. But there is always this gap between averages in population studies and the particularities of individual people and patients. And so this leap happens when we apply population evidence to individual bodies. And that means that sometimes when we talk about overdiagnosis, the response we get is, so what, most in situ breast cancers don't metastasize, okay, but mine might. And that happens when this leap occurs between the average in the population and this particular person who's really worried about developing cancer. A patient once likened it to me as like saying, well, don't worry, most people in this room probably don't have a bomb strapped to them. You would probably still worry, is how this experience felt to them. And that's partly because of their particular idea of what cancer is. It's a progressive and terrifying disease. So our statistical work on populations isn't necessarily compelling at the level of individual, and we somehow have to reckon with that. Perhaps another challenge might relate to our conceptual framework. So I think for some people, the term overdiagnosis can seem to imply a binary between a helpful diagnosis and a harmful diagnosis, a kind of this or that. And we know that people's clinical and lived realities are much messier than this. There's rarely a clean-cut line between a useful diagnosis and an overdiagnosis. But maybe this is a binary that sets us up for polarization and implies a kind of black and white thinking. And finally, I think sometimes polarization is fueled by our tone. We have a tendency to talk sometimes in terms of we're right, they're wrong, and sometimes we talk about proponents of early detection as irrational, anxious, maybe brainwashed. At the last conference on overdiagnosis, I heard a researcher describe women who attended breast screening as stupid. And there's name-calling on both sides. Researchers working on overdiagnosis are sometimes called people in tinfoil hats or conspiracy theorists, and it's not surprising that silos form as a result of this kind of hostility. So how can we move beyond polarisation? How can we better engage with people who don't agree with us? So I'm going to talk through those 5 things again and think about how we might consider them differently. So firstly, I talked about this progressive model of cancer, which underlies all of the early detection work. So there have been some efforts to offer alternative models of disease change. So this is an image from the website Cancer Rose, and it's showing the potential change of breast cancer in a less linear way, so more like a bush of possibilities. And it's presenting a challenge to this fundamental idea that cancer is a progressive disease. And I think having alternative models is useful because it means we're not just saying, well, that linear model is a bit misguided and maybe misguiding in certain cancer types. It means we're also offering different models for people to think with. And potentially having an understanding of cancer as this, rather than the kind of linear trajectory towards death, makes a cancer diagnosis less terrifying and less like being in a room with someone who's wearing a bomb. So I talked also about how one of the reasons early detection is compelling is because it's really hopeful. It offers this compelling vision of what it means to live well. It says, if you are a compliant, responsible patient and citizen, maybe you can avoid disability and disease, and maybe premature death as well. And our work on overdiagnosis presents a critique to this vision. We're saying, well, this might not work as well as you think, and it might also have harms. But we don't always offer a compelling alternative model of how to help people live well. And I think that means our work isn't necessarily very inspiring. So I wonder if we could spend more time thinking about offering alternative notions of hope. If our problem is with the medicalised notions of prevention, what might alternatives be? And I want to just briefly mention one possible example. So in the UK, deprivation is a really strong risk factor for cancer. You're more likely to be diagnosed at stage 4, and you're more likely to die of cancer if you live in a deprived area. Deprivation also makes it harder to engage with other forms of prevention which have come into the remit of medicine. So these kinds of lifestyle changes, which we've heard a lot at this conference, have become really commonly advised in recent years. So things like be smoke-free, keep a healthy weight, drink less alcohol, and so on. This is obviously a poster from Cancer Research UK. And another poster showing that if you're from a more deprived background, you're much more likely to smoke than people from less deprived backgrounds. I also wanted to draw attention to one of these smaller ones here, which says avoid air pollution, which is not necessarily the easiest thing to do. This is a report published in February this year. It's about beautiful leafy Oxford, where I live. Oxford is also subject to poor air quality, including having issues with types of particulate matter that are deemed to be carcinogenic by the World Health Organization. And I cycle through it every day to get here. And again, pollution is a risk factor which is unevenly distributed. This is a UK study, and it shows the percentage of households living in poverty against the concentrations of key pollutants, and it shows that if you live in poverty, you're much more likely to be exposed to higher levels of nitrogen dioxide, and particulate matter. And just as a side note, the second graphs show that if you live in poverty, you're less likely to contribute to those emissions through private vehicle ownership. So this is an inequalities issue. And perhaps it raises questions about images like this one, and maybe whether they would be more accurate looking something like this. And I want to be very clear that I edited this image, Cancer Research UK did not. They had nothing to do with it. And obviously, I'm being facetious. But my point is that our public health response to the problem of deprivation has sometimes been to offer measures like targeting lung screening or stop smoking campaigns at deprived communities. So they focused on encouraging individuals from deprived backgrounds to better comply with early detection interventions. And we've done that sometimes instead of thinking about how we might address deprivation in itself. I want to pose this as a provocative question. What if we made addressing deprivation a fundamental part of our work as the overdiagnosis movement? And this could be part of offering alternative notions of hope. So it's not just that we're saying early detection is a bit rubbish sometimes, it's that we're also offering alternative visions of how we can help people live better lives outside of medical intervention. And that might also involve expanding the limits of what we see ourselves to be responsible for as health researchers. I then talked about this heavy reliance on evidence-based medicine and population studies which aren't necessarily compelling to individual people. And I think this is where we need to accept the limits of evidence-based medicine. There will always be this gap between populations and individuals, no matter how focused we make those populations. And we know that evidence is only one part of how people make clinical and public health decisions. So I want to suggest that ethics also plays a big role, and concerns about overdiagnosis are as much about ethics as they are about evidence. And I see this in my work on cancer screening all the time. At least in the research world, it's not that proponents of early detection are unfamiliar with the harms of screening, it's that they prioritise the likelihood of possible benefits, perhaps however uncertain, over the risk of possible harms. And this also explains these papers we've seen, this research that shows that when members of the public are talked through information on overdiagnosis, on cancer specifically, it doesn't necessarily change their intention to attend screening. In fact, it rarely does. And here it's not that they don't understand, it's that they ethically benefit the value of doing over the benefits of not doing. So we could think of overdiagnosis as an ethical position regarding the value of medical intervention versus not providing medical intervention. And I would argue that people choose a position in this debate based as much on values as on evidence. And in our kind of staunch focus on RCTs and the numbers, we perhaps miss that. And I'm back to the self-promotion. This is where storytelling, I think, can be really important. So in the session today, I will talk about this kind of lived experience of medicalisation and overdiagnosis, and my colleague Rupal Shah, who's a GP, is going to talk about how she reckons with these questions as a GP, and she's got some examples from her clinical practice. And we hope that using storytelling can help enrich evidence-based medicine by making these on-the-ground complexities and ethical questions visible. And I think this links to what Iona Heath was saying in her keynote yesterday about the importance of the local and the particular. So I also mentioned this kind of conceptual issue perhaps with overdiagnosis. And I wonder if we've reached a point where there might be value in thinking about alternative conceptual tools. Perhaps those that are less binary and less polarised, and maybe more specific. So in the field of cancer, would it be more productive to talk instead about cancers with a low likelihood of progression? So we're avoiding this kind of polarised binary and maybe being more precise. Would that conceptual framework get us further, particularly when talking to people who might not agree with us? I'm not sure. And finally, I think we need to resist the temptation to characterise people we disagree with as stupid. It's the hottest take of them all. And instead, can we think about adopting empathy and trying to understand why people push medical interventions with weak evidence of benefit? And sometimes it has to do with commercial drivers and greed and all the rest of it, for sure, and that's often part of it. But there's also this role of hope and of grief, and I think we have to work with that. Can we make a more conscious effort to resist silos through outreach and conversation? And maybe having different conceptual frameworks would help us do this. So just to wrap up, I've suggested that this field, particularly the field of cancer, is plagued by polarisation for a number of reasons, and it makes engaging with people who disagree with us really difficult. I've suggested that thinking about new conceptual frameworks regarding disease progression and overdiagnosis, and thinking about alternative narratives of hope, may help us better engage with people who disagree with us in the future. And my final bit of self-promotion is that I'm turning this project into a book, and please do connect with me if you're interested in hearing more about it. I think the bottom line here is that we do need to think differently about how we engage with people outside of our movement, and the question is how. And I invite collaborators who want to think through these challenges together to get in touch with me. Thank you very much for listening.